Ready, off we go. Yeah, admit. Good evening to everybody. A very, very warm welcome to everyone. I, Anita Jatana, consultant dietetics in the Apollo Hospital, Delhi, would like to extend a very warm welcome to all our esteemed speakers, moderator, and participants for another GAPIO session, which is in collaboration with global dietitian community. This session is a very interesting one that I think we've never really focused on, and the session is post-ICU care syndrome, which is being organized by the GAPIO and the GAPIO Dietetics International Lecture Series. We have Dr. Harsha, a senior consultant, Department of Internal Medicine and Critical Care, Apollo Hospitals, Bangalore, who will be speaking on post-intensive care syndrome. And we have Dr. Reema Sultan, a clinical dietitian at EHS Critical Care, AI Kuwait Hospital, Dubai, UAE, who will be speaking on nutritional therapy to prevent post-ICU care syndrome. Dr. Sandhya Singh, who is the HOD, a friend of mine, Department of Nutrition and Dietetics, Apollo Hospitals, Bangalore, will be moderating the session. So we are all very alert and attentive with patients in ICU. All of us, doctors, medical nurses, everybody. But we should be equally vigilant for them during the post-ICU stay. We somehow, tend to relax, all of us, that he's out of critical care and he's on the road of recovery. But the short-term outcomes of ICU patients have dramatically improved over the last half century. But it is now increasingly recognized that many ICU survivors experience this post-intensive care syndrome, which is a collection of physical, cognitive, and mental health issues that these patients experience after surviving a critical illness and spending time in the intensive care unit. All alone, isolated, new faces, all in town. So they're definitely a fear syndrome. PI fix can affect both patient and their families, leading to long-term consequences that can persist for months or even years after discharge. Some of the physical symptoms I think we are all very well versed with are muscle weakness or fatigue, and you would have all experienced post-COVID, joint pain or limited mobility, respiratory issues such as shortness of breath, difficulty with basic self-care activities. The cognitive symptoms faced by them are memory problems, difficulty with attention, and confusion. And they all have mental health symptoms also like anxiety, depression, and flashbacks and nightmares, which they must have felt in the ICU. The family also experienced bad symptoms like anxiety and depression, sleep deprivation and helplessness, and of course, financial and social strain. All of us realize, when patients are there in ICU, they are well looked after, but the families have no place to stay. So the management and rehab addressing this often requires a multidisciplinary approach with medical, nutritionists, physical therapists, occupational therapists, and cognitive rehab. So moving forward, over to the expert to enlighten us on this important aspect of nutrition, which we have really not been focusing on, and we have reputed well-known speakers here. Taking this forward, we'd like to invite Dr. Sandhya Singh, HOD Department of Nutrition and Dietetics, Apollo Hospitals, to take this program forward. She is a PhD in nutrition from Mysore University with more than 22 years experience. She is the convener, Indian Dietetic Association Bangalore chapter, has completed the Low FODMAP diet course from Monash University, is an SNLL certified in many areas. She is the expert for renal nutrition course in SVT College. Has a lot of chapters to her credit in various books. Has won Excellence Award in Medical Nutrition Practice and has published various papers in national and international journals of nutrition. So over to you, Sandhya, to take this forward. And I would
Thank you,
request
ma'am.
everyone to be muted during the session and do post your questions in the chat box. Over to you, Sandhya.
Thank you, Anita ma'am, for those kind words. At the outset, I would like to thank Anita ma'am and the GAPIO team for giving me this opportunity to moderate this session. And I want to thank Anita ma'am once again for setting up the context for us. Without taking a lot of time, I would like to introduce our eminent speakers who are going to touch on this topic, that is post-ICU care syndrome. We have Dr. Harsha, who is the ICU intensivist, who's going to talk about, how, important it is for us to ensure that we will take care of the patient even after post, ICU discharge. So Dr. Harsha is specialized in managing critical care, medical, cardiac, and post-surgical patients, including renal and hepatic transplant recipients. He performs diagnostic procedures, manage airways, manage ventilators, perform vascular procedures, and provide basic and advanced cardiac life support. He also develops ICU protocols, manage outpatients, holistically manage patients, manage diabetes, and practice preventive medicine. Dr. Harsha is a teaching faculty member of Apollo Hospitals, Bangalore, and has been recognized for declaring brain stem death. His interests are ARDS, heart-lung interactions in ventilated patients, ECMO and tropical diseases and sepsis, and also critical care nephrology. He is a senior consultant of internal medicine and critical care at Apollo Hospitals, Banagatta Road. Over to you, Dr. Harsha, for the session.
Thank you so much, Dr. Sandhya, for the kind introduction that you gave. It was very generous of you. So I again thank Dr. Anita, Dr. Jitendra, and entire GAPIO team for having me here. I think Dr. Anita pretty much encapsulated whatever I had to talk basically. She has given in a nutshell the whole talk basically. So, good evening, dear friends. So, the thing is, in an ICU, in a critical care setting, as we all know, the emphasis and the focus is always on short-term mortality. Basically, we want to reduce the short-term mortality, improve the ICU survivals, and pretty much we are there. Basically, we have been able to do so, and thanks to the advanced therapeutics which are available and the protocolized care that we render in the ICUs have made it possible. But the thing is, we have been increasingly, it has become obvious that ICU survivorship alone doesn't, it is not tantamount to cure. It doesn't equate with recovery, basically. So we have seen many patients, critical care survivors, they get discharged, they go back home and continue to suffer with a lot of a myriad of symptoms, basically, which reduces the quality of life, which increases the morbidity, and eventually it increases the mortality as well. That is post ICU mortality. All of these symptoms per se, they have been encapsulated and they have been brought under one single heading, that is called post intensive care syndrome, or PICS, if I may call so. So, what is post intensive care syndrome? The next slide, please. The next slide. Will I be able to? Yeah. So, PICS says any new or worsening impairment in physical health, cognitive health, or mental health status which arises in people who have just come out of critical illness, and this persists beyond acute care hospitalization, and it can run for months to years. Basically, we have seen people suffering with various symptoms beyond the four walls of ICU, and this is a very important concept at this point of time. The next slide, please. So is it a new term, the PICS? It is definitely not a new entity. It was coined way back in 2010, and it was in consensus by a task force which was set up by the Society of Critical Care Medicine. But of late, the interest and the awareness has increased, and we need to probably give the credit to COVID, the COVID experience, whatever it has taught us. We had seen significant number of COVID survivors going back home, not just the people who had got affected with severe COVID, even the ones who had moderate COVID, they continue to suffer for months to years. So COVID should get the credit for probably bringing up this particular term or probably this entity into the foreground. So one other thing is PICS is not a clinical diagnosis per se. So when this particular term was coined, it was coined to fulfill certain objectives, and the objectives mainly are basically to increase the awareness that such an entity exists among the clinicians, the patients, the families, as well as public in general, to increase the screening for multiple derangements which happen in critical illness, and to probably facilitate research in certain morbidities which probably would improve the post ICU care, as well as we can reciprocate the same when the patient is still in the ICU. So the next slide, please. So coming to the symptoms, so as Dr. Anita had told in a nutshell, so from the individual perspective, the PICS affects the mental health of an individual, it affects the cognition, it affects the physical progress of an individual, and this is at the individual level. We shouldn't forget the caregivers, the burden that they face, the change in the family structure, the grief associated, mental health issues. All of these basically are acknowledged by the Society of Critical Care Medicine, and the impact on the family. This dimension is also given importance. And one other important, which definitely we cannot avoid, is basically this financial toxicity. So, as you know, the ICU care doesn't come cheap. It is quite expensive. The medical bills are definitely above board, and the job loss, which is associated with the physical ailment, probably loss of home, loss of savings. All of these put the patients significant duress upon the patients as well as the family. So next slide, please. So coming to the mental health perspective, the symptoms which we are seeing from the psychological perspective mainly are anxiety, post-traumatic stress disorder, and depression. So in a cohort study which was done in UK, it was found that anxiety affects almost 62% of individuals post discharge from the ICU. Post-traumatic stress disorders in about 39% of individuals, and depression in about 36% of individuals. So there is a tendency towards deliberate self-harm, suicidal ideations, and erectile dysfunction. All of these are seen in people who survive the ICU admission. Next slide, please. So coming to the cognition, the most important symptoms we see are decline in memory, executive function, a reduction in attention span, the concentration, mental processing speed, this psychomotor slowness which is seen in these people. All of these are very important to go towards a goal basically. So this disruption in goal directed behavior increases the predisposition for these people to become dependent on activities of daily living. So which definitely reduces the healthcare related quality of life, and this particular thing increases the chances of these people going into depression. So it is basically a self perpetuating vicious cycle. Next slide, please. So coming to the physical health of an individual, the most important thing which we look at is ICU acquired weakness. So many people, even after discharge from the ICU, continue to have muscle weakness, which could be related to myopathy or neuropathy, which is very common, especially in ventilated patients. We see a lot of people on ARDS, and the more they stay on ventilator, the more the sedation, relaxants, the steroids that we use, these people land up with ICU acquired weakness. So ICU acquired weakness definitely reduces mobility, it reduces self-confidence, they become ADL dependent, and this is a harbinger for need for oxygenation, ventilation, probably a harbinger for bed sores, hypostatic pneumonias, etc. The second thing is an impaired lung function, more common in ARDS, and the more severe ones tend to have more impaired lung function. This was again pronounced in people who got discharged after the COVID infection. So the need for oxygenation, the need for tracheostomy, the need for mechanical ventilation back home, all of these things are associated with this particular thing. The other thing is the malnutrition and the associated cachexia and sarcopenia. This is a very important thing, and this emphasizes the fact that we need to have we need to look at the nutrition state of a patient who is admitted, and a thorough nutritional assessment and dietary supplementation goes a long way in probably reducing both the ICU morbidity in the ICU as well as out of ICU morbidity. Sleep disturbances are seen in these individuals, and it could be sleep onset disorders, nightmares, sleep sustenance disorders. And again, these sleep disturbances predispose a person going into anxiety, depression, and things like that. So naturally, we can see that this thing reduces the physical impairments, they reduce the healthcare related quality of life, and all the three dimensions, be it physical, the mental, the cognitive dimensions, all are interconnected and they can self perpetuate one another. The next slide, please. So what are the risk factors for development of PICS basically? We have certain non-modifiable risk factors which we can't do much about. The elderly age group, increased frailty, and female sex, the sex, they are known to have increased predisposition for having PICS. Pre-existent disability, whether it is physical disability, cognitive disability, these are the things which can again predispose them to have a higher predisposition to having PICS. ARDS sepsis, and the severe ARDS, the severe the sepsis, the higher the chance that the patient would leave the ICU with some amount of debility. Potentially modifiable risk factors are mechanical ventilation. So the less the patient stays on mechanical ventilator, the less the stay in the length of stay in the ICU definitely goes a long way in reducing the risk of PICS. Reducing the duration the patient is in shock and probably reducing hypoxic episodes and probably curtailing multiple organ failure with early goal-directed therapy are potentially modifiable ones. The most important thing is basically to be able to identify the modifiable risk factors and probably appropriately treat them. So the most important modifiable risk factor is sedation. So we know that in ICU, most of the people who are on ventilator definitely would require some sedation. And though a light sedation protocol is what is followed at this point of time, in the initial phases of ARDS, they would require a high sedation basically. So reduction in the dose of sedation and probably moving away from the use of benzodiazepine is one way to reduce the risk of PICS. Delirium, early recognition and treatment of delirium is one other thing which could probably mitigate the risk. Early mobilization of ICU patients is very important and address the sleep disturbance in the ICU probably from the pharmacological front as well as non-pharmacological front, like reducing the sound in the ICU, which is it has become ubiquitous now. The sound is definitely a disturbing thing which probably we need to ponder about. And hyperglycemia is one of the risk factors. Basically, having a good glycemic control is very important to mitigate the risk of having PICS. And there's another concept called maintaining ICU diaries. Basically, we have to encourage the conscious patients and probably the families to maintain ICU diaries to jot down what are the negative memories that they had in the ICU, what made them to incur pain, and probably what are they are expecting from the treating team, and probably addressing those needs definitely helps in reducing the risk of having PICS. So next slide, please. So as we have already touched upon, we cannot disregard the family. The family goes through a lot of emotions and the financial toxicity as well. So we have, this is acknowledged by the Society of Critical Care Medicine, and this entity is called PICS family. Basically, the prevalence in various studies it can range from as low as 6% to 69%. Most of the symptoms are pertaining to anxiety in about 73% of individuals, depression, post-traumatic stress disorder, and complicated grief. So this could last for more than 6 months, probably years. So which reduces the healthcare related quality of life as well. So next slide, please. So coming to the risk factors of developing PICS among the family members. So we have something called patient-related risk factors like increased severity of illness, death of a loved one can predispose. From the caregiver perspective, younger age group, if the caregiver is of younger age, child of an adult patient, the financial instability, reduced educational background, reduced social support system, which we saw in COVID. When people went into quarantine, the social support system was significantly altered. These are the things which can increase the risk of having symptoms in the family. From the environment perspective, again, poor communication with the staff. So it's very important to empower the family, have a good discussion with them, make them understand the whole aspect of the critical illness of their loved ones, and probably involve them in the rounds and probably decision making. These are very important to take care of the PICS in the family. So there are certain complicating factors as well. So the caregiver burden, job loss, which can probably affect both the individual, the patient, as well as the family members. And again, the financial toxicity, all of this can complicate uh, uh, the pigs in the family. So next slide, please. So it just doesn't end there. It is not just the individual and the family. We have different socio-economic dimensions, and there are various. We see a lot of healthcare inequities and disparities in various levels, and all these things can exacerbate pigs, and in turn, the pigs can exacerbate these socio-economic disparities, basically. So at the individual and family level, we have already spoken about. And from the community level, as well, reduce lower socio-economic position and probably a neighborhood socio-economic disadvantage, basically not having healthcare facilities in the neighborhood, limited transportation facility, increased distance from the clinics. All of these things can increase the burden on the family as well as the individuals. From the healthcare systems, non-availability of PICS clinics will come there in the next few slides. Reduced social support, probably underperforming long-term acute centers or weaning centers. All of these exacerbate the chances of having PICS. And from the policy perspective, actually reduced access to health insurance, probably reduced PICS clinic services, social welfare support, all of these things need to be kept in mind. So it is not just the family or the individual getting affected, it has definitely influence over the community, it has influence on the health systems as well as the policy and the policy makers as well. Next slide, please. So how do we go about treating these patients? Basically, we have understood that the magnitude of the problem has been understood, and we need to look at how comprehensively we can probably address these individuals, because most of these people, they go into different zones in the hospital. Probably they go to the psychiatrist, they may probably go to the physiotherapy units and things like that. But the concept of PICS clinics, probably it is not as it's not very well established in this part of the world, but definitely there is a in the previous. Yeah. So, there is a definite need to probably understand this concept and probably bring in such models in our country as well. So, PICS clinics are multidisciplinary ICU recovery programs involving a lot of caregivers. Basically, we have the intensivists, the pulmonologists, psychiatrists, clinical psychologists, the dietitians, physiotherapists. A lot of these individuals, they work under one single roof and provide a holistic care for the ICU survivors. So it has been seen that it reduces. So actually, the concept of PICS clinics reduces the mortality, morbidity, and increases the health-related quality of life. So it was recommended in the latest Surviving Sepsis Campaign Guidelines, 2021 guidelines. The concept of PICS clinics was recommended. The next slide, please. And there is a model of transition of care which is recommended by the Survival Sepsis Campaign SSC. So the thing is, the patient who is admitted in the ICU, when the time is appropriate for him to get discharged, so there would be a discharge navigator. So it could be probably an intensivist or an in-charge nurse who decides whether the person is fit to go home or probably is not fit enough to go home and probably requires a subacute care in one of the weaning centers or probably rehabilitation centers. So it is the responsibility of the discharge navigator to arrange a visit into the post ICU clinic 2 to 4 weeks after the discharge from the ICU. So in the post ICU clinic, a lot of these dimensions are assessed and evaluated and managed by a multidisciplinary disciplinary team, as I told you, and which to provide a holistic health for ICU survivors. Next slide, please. So what all evaluation and the management protocols are followed in PICS clinic, basically. So all the domains, the cognitive domain, physical, psychological, all the domains are looked after in the PICS clinic. And we have different assessment tools for different domains. Basically, from the cognitive domain, we have a mini mental state examination, Montreal Cognitive Assessment, Barthel Index. These are all numerical scores which will tell the severity of cognitive disturbance. And from the management perspective, the cognitive retraining, exercise therapy, occupational therapies, these are the things which can be probably provided. From the physical domain, basically, as far as the respiration is concerned, we have tools like spirometry, 6-minute walk test, modified medical research council scale to assess the dyspnea and probably respiratory compromise. And during the PICS visit, the people who were discharged from the ICU and they were kept on long-term oxygen therapy, people who were discharged with non-invasive ventilation, so we can probably titrate the dose of oxygen, titrate the settings of the BiPAP or the CPAP which they are on, breathing retraining and pulmonary rehabilitation, the tracheostomy care, all of these can be assessed. So from the perspective of a general physical health, we can review the ICU course, assess any new symptoms, medicines, whatever the patients were taking, because that is one thing which we need to look into. We need to revisit the medications and probably cut a few ones which are not deemed important, and screening for health maintenance can be done. And we can probably at that from the management perspective address any reversible causes of PICS, any new symptoms or medical conditions can be addressed, and if needed, a specialty referral can be taken basically based on the symptoms. ICU acquired weakness, as I told you, is one of the very important aspect of post-ICU care. So assessment of the muscle power is done by lot of scales are there. We have the Berg balance scale, we have the manual muscle testing, we have the 5 times sit to stand testing, and the hand grip dynamometry. All of these can be used, and in the clinics, they can be provided with mobility aids, graded exercise programs, and physical therapy. From the psychological perspective, we have again scores. We have the hospital anxiety and dementia score. We have the impact of event survival scores. So it can be assessed from the psychological domain, and probably psychotherapy, psychiatric referral, and creating support groups among the patients as well as the families who are in the same zone can probably be facilitated. So next slide, please. So we need to look into the barriers which prevent the people coming into the PICS clinics as well. So increased age, severity of illness, probably dependence in activities of daily living, and frailty from the patient's perspective. These are the barriers which could probably render them incapable to follow up in PICS clinics. From the financial aspect, the financial losses, the cost of transportation, lack of health insurance, these are the things. And from the environmental perspective, the availability of PICS clinic, the distance to the clinic, lack of caregivers, these are all the barriers to follow. So, next slide, please. So, I'll just come to the last slide. So, to summarize, it's very important to understand that ICU survivorship is often complicated by post-intensive care syndrome, which has significant physical, cognitive, and psychological impairments. And it can impact not just the individuals, it can impact the family, the healthcare system, and the society as well. And post ICU clinics are very important, and the need of the hour is basically in this part of the world. It is important to recognize the dynamics of post ICU clinics and probably get going with suitable models so that we can use to probably provide a holistic care, and they may represent a way to manage these patients better. And probably all the data and the experience that we collect from the PICS clinic probably can be used in the ICU to prospectively improve the ICU care and reduce the risk of the survivors going into the PICS. So thank you so much for having me. Any questions, I'll be happy to take.
Yeah, thank you, Dr. Harsha, for a very insightful and a comprehensive session. You have touched everything in so much detail. And it was like, I was visualizing our rounds in the ICU where we used to do our multidisciplinary team rounds. So it was a very nice talk, very practically, the points were put across. So I have one question. See, when you said that the family needs to be counseled in detail about the patient's condition, and what are the strategies that you generally follow in your setup? Would you be able to share your experience?
No, see here on a daily basis, at least in our center, on a daily basis, from the intensivist viewpoint, we counsel the families. And if at all there are multiple modalities which are involved, probably the primary physician needs to take the responsibility of interacting with the various other consultants who are on board and probably give a gist of the whole the entire perspective of the care has to be discussed with the family. So here we conduct family meetings, we take care of, we clear all their doubts, whatever their queries or questions are, we look into that aspect, and we encourage them to probably talk to the relatives, get into the ICU, probably give more time with the, especially those people who require more of emotional care than primary critical care, basically. The people who come out of the ventilator support, probably coming out of critical illness, they require more psychological support. So we try to empower families basically to be with the patients and probably use the time they are in the ICU in a meaningful manner. So this is what we do.
Dr. Harsha, just one question to you.
Yes, ma'am.
Do we normally call in a psychologist or somebody else, or do you wait? Is he going into depression, or do we have it as a sort of protocol? What do you do?
No, no, ma'am, we have it
No.
because the delirium score is very important, because assessing the delirium and appropriately treating them is the most important thing here. So we assess delirium on a daily basis, and we look at addressing them. So with pharmacological means or non-pharmacological means, basically mobilization and probably getting them to a well-lit place in the
Yeah.
ICU. Basically, these are very important. And again, empowering the families to be by the side of such individuals definitely goes a long way in probably reducing this particular thing, ma'am. And it is done in a preemptive fashion. It isn't done once it is set in, basically. Definitely, it is a preemptive effort to make sure that we are addressing these issues before the major manifestation kicks in.
So yeah, most of the ICUs I don't think even have a window, so they don't know when it's day, when it's light, how
Yeah,
many days have
actually, yeah,
gone.
that is true. That
So
is true.
we used to first call it just ICU syndrome. Now we're giving it another name.
True, ma'am.
So they say, what role has Sandhya? You are handling this, please. There's a question in the chat box, Sandhya.
Yeah.
What take over
What
to you, Sandhya.
role does early identification and intervention play in the management of PICS?
Ma'am, I didn't get you. Come again, please.
What role does early identification and intervention play in the management of post-ICU care syndrome?
So definitely early identification, as I told you, the early identification of risk factors basically from the patient's perspective, that is looking at the sedation, the delirium, mobility issues, probably looking at psychosocial issues as well, and probably addressing them definitely goes a long way in reducing the risk of having PICS. So the same thing I just enumerated those things. Basically, it's very important to address delirium. That is one of the most important thing. Whether it is hyperactive delirium or hypoactive delirium, it's very important to recognize that a person is not just sedate and he's keeping him forward to himself. So a person who is probably not, he's just keeping to himself in the ICU cannot probably is not a calm patient anymore. He may be probably having a hypoactive delirium. So we have scores, we have CAM ICU score. So it's very important to use those scores, probably pick up the delirium early and treat them. And as I told you, the ICU diaries as well. Encourage the patients who are conscious to make a note of those interventions which probably brought about pain, what made them feel that pain, and probably we can take their suggestions, what would make them feel better, basically, and try to incorporate those things in our ICU practice.
Yeah. I have another question, Dr. Harsha. Are there any specific trainings or educational resources you recommend for the healthcare providers for better understanding and to manage PICS?
From the perspective, actually, that's what my multidisciplinary approach is very important. I think from the hospital front, if not from the policy makers front, individual hospitals probably need to, the different teams have to come together chart out a program, and probably they train the individuals basically, because the dynamics is lacking in any of basically the dynamics are lacking. So we require more understanding, and probably we need to set up a a viable model basically. So definitely setting up, having a thought towards that, and probably acting is very important. Basically.
Yeah, I agree. The dynamics are really. Sorry, ma'am. Sorry, please go ahead, ma'am.
No, please, Sandhya. Yeah.
No, please go ahead. The voice
Yeah,
was.
I think it's really a difficult scenario, and there's definitely a lot of teamwork. I think all of us been through the COVID times. I think all of us got COVID once, and I think we had all these symptoms because we couldn't see anybody's face. We didn't know who was what. So isolation definitely was very, very frightening. So I think that's what all these patients in ICU feel, and all those machines around them are scary. So I think it definitely is very traumatic on them. Dr. Harsha, thank you. Very, very excellent session
Thank you, ma'am.
with lot of insights.
Thank
Any
you.
other questions, Sandhya?
Sorry, ma'am.
Any other question? Or I think that Dr.
Yeah,
Harsha.
one last question is.
Okay, yeah.
Yeah. See, whenever you are intervening the patient, do you have any specific strategies that you keep in mind to ensure that you minimize the post-ICU syndrome, the complications that the patient undergo post-ICU discharge?
Yeah, ma'am. The thing is, weaning trials, we always go. The sedation is the most important. So light sedation protocol is what is used. We have again a sedation scale. We have a RAS scale basically. We maintain a light sedation so that the patient is not discomforted basically with the tubes in place and probably the ventilator breathing for him. He is able to maintain synchrony with the ventilator, but he's quite conscious. And again, probably talking more with such people. Basically, we need to express ourselves, and we need to give them charts basically, because obviously they're not able to communicate verbally. Visual charts wherein they can be able to just point towards the alphabets and probably making up for a sentence and probably expressing themselves. That definitely helps in we have those charts in our eyes. We follow them.
Okay. Okay. Thank you. Thank you, Dr. Harsha. Thank you for a very insightful talk and for handling the questions very well.
Thank you. Thank you so much.
Thank you.
Thank you so much, Dr. Harsha.
Thanks a lot, ma'am.
Grateful. Grateful.
Yeah. So we are moving ahead with the next session. The next topic is nutrition management in post-ICU discharge. So we have Dr. Reema Sultana. She's a clinical dietitian in Emirates Health Services at Kuwait Hospital, Dubai. She's a clinical dietitian specialized in critical care and cardioendocrine specialty. She holds ESPN diploma in critical care, and she's a member of Policy Guideline Committee, Emirates Health Services, and she provides hands-on training and development to dietetics graduates and postgraduate dietitians. She is a JCI coordinator for quality and excellence hospital sector, and she is the committee member for hospital therapeutic catering from plans to plate. A warm welcome to you, Dr. Reema. Please take over.
Very good afternoon to all of y'all. First and foremost, I'd like to thank all of y'all for having me on this session, giving me the opportunity, and it's really nice. Like I read from Dr. Sandhya, you are teaching in SNDT University. My base is from SNDT University. So it is basically India that has made me, and proud to say that I'm an Indian and given this opportunity. Thank you so much. Thank you, Dr. Anita, Dr. Sandhya. Thank you, everyone, and all those who are on the team. Now, let me quickly start with my presentation. Like Dr. Anita has already spoken all about the post-ICU syndrome. Also, Dr. Harsha has spoken all about it. I will look at it more from the nutritional aspect, as we as dietitians would be most interested in. Now, nutrition care post-ICU discharge. Nutrition care, as for me, doesn't only start after ICU discharge. We as dietitians need to take care from the day the patient has set the first step into the ICU. In fact, sometimes at our setup, The patient moves in from the medical, and by the next day, that's what we see most often in those suffering from COPD or those who had COVID-19, moved from the medical wards or the surgical wards up to the ICU. So our care should start from the time the patient enters the hospital. Now, can we go to the next slide, please? Okay. I really like this saying, complete bed rest is not beneficial. It may be associated with harm on long term. We all saw this during the COVID-19 phase, that when exercise was induced or when the patient was made to go on the prone position, physiotherapy was introduced. They had better outcome as compared to those that were totally isolated and left alone. Now, we need to take care that we're creating survivors and not victims. We don't want to create more and more victims of post-ICU. We want them to go back walking on their feet when they get discharged from the hospital, or see them post 6 months coming back to the clinic, at least more able and more, not a lot of loss of muscles and not entering into the sarcopenia phase. This is what is most important. Next slide, please. Okay, so what we talk over here in the objectives will be meeting the needs while in ICU, assessment pre-discharge from the ICU, home care plan, and quarterly follow-up for the patient. Next slide, please. Next slide, please.
Dr. Jitendra? Just a minute, Reema.
Yes, ma'am.
Next slide.
Next slide.
Just wait. Sorry.
Okay. Now, looking at this chart, this is a research which has been released, or a paper which has been released just in July of 2024. It's very beautifully presented, the entire presentation that I'm going to talk about. When we look at the patient entering the ICU, we have the day 1 to the day 2, which is the early acute phase. Here, what we need to look at is if the patient is able to eat orally, of course, yes, oral first. If the patient is not able to eat, then an early enteral nutrition will prevent development of infections, or the patient moving into a lot of loss of his lean mass. Then comes the 3rd to the 7th day, that is a late acute phase, where we need to reach the patient's energy requirement from 80 to 100%, and the protein can be slightly increased from 1 to 1.2. Then coming from the day 7 is the subacute phase, where we can go slightly higher than the 100% for compensating for all the loss or the low value of energy or the low protein that we've given him during the first 7 days. So here we take the energy requirement more than 100%, and we can go for protein from 1 to actually 1 point or 2.5 as well, depending upon the condition of the patient. Like you can see, early acute phase will be the early enteral feeding. So oral goes first. If no oral, then we go for enteral. If no enteral, then we go for peripheral parenteral. Then coming to the later cues, progression towards the adequate feed, which is from the 50 to 70, 75% or 100% if the patient is possible to tolerate. The day 7 onwards, full adequate feeding should be introduced. And if the patient is not able to start on enteral until this time, we start on peripheral parenteral. Next slide, please. Okay. Introduction. Mortality due to critical illness has fallen over decades, but we are seeing that long-term functional disabilities has increased, impaired quality of life, and there is a significant health cost that was discussed by Dr. Harsha also. About 65% of the ARDS survivors suffer from significant functional limitations. About 50% of the patients post the ICU will return back to their normal job within 1 year period. And about 45 to 50% are not able to go back. They do not have the strength. They are not able to concentrate. They do not have the mental health. So our aim should be, when we discharge a patient from the ICU, we follow up with these patients so that we're able to return them back to life. Within 1 year's time, they go back to where they've started from. Next slide, please. Early enteral nutrition, like I said, is recommended. It is superior over delayed enteral nutrition. Sometimes we face this issue in the ICU where the doctors are not very confident of starting. So what do we do at this point is we introduce the patient to trickle feeding, which is only to keep the gastric working, which is to prevent the movement of the bacteria up towards the intestine, and give them confidence over time that a trickle feed will not actually alter any of their values, especially the lactic acid, which will go shooting up in case we're going to start with 100% of the feed. So start with early trickle feeding. Then by the subacute phase, you can go from 20 to 40 ml delivery, and then gradually proceed in the next 48 hours and go up to 40 ml and further on to meet 100% of the requirement. Now, an energy intake of 70 to 80% of the measured EE is optimal, whereas lower or higher, both is depending upon the patient's increased mortality. So we do not even want to reach 100% requirement in the first or the second day, where we want to give the body able to distribute its energy or concentration into different organs functions, not only just busy digesting the food that we pumped into the body. Let's go ahead. Next slide, please. Okay. Several studies have shown that a caloric restriction, like I said, trickle feed, about 500 kilocalories a day or less than 50% of the target for the first 2 to 3 days is very essential to prevent mortality from refeeding syndrome, which we have to remember because the patient will develop hypophosphatemia. So we need to go slow. Next slide, please. A catabolic response leading to reductions in muscle mass up to 1 kg per day can happen if proper nutrition isn't being started. So please take care that you start the nutrition and your doctors are with you. Go slow if they're not very confident, if they're not very happy with this thing, they are complaining that the patient is not stabilized. Yes, once he is stabilized, please start on nutrition. This is from my experience. When you give results, your doctors do support you. Usually the dietitian community always is complaining, our doctors don't agree and the feeds haven't been started. Well, go slow, give them confidence, show them results, and I'm sure they'll work along with you. Next slide, please. Okay. Again, going through the same thing. Acute phase. I really like this chart. It really puts across everything very clearly. On the day one would be 25% of the requirements gradually if the patient is showing improvement and tolerance. Don't forget this, very important. So day two, there is nothing called as just book knowledge. It's all about practicality and looking at the patient's blood values. Now, if the patient is on the day two and tolerating 50% of the requirement, day three about 75% of the requirement, by day 400, then we have a post-ICU target where we have to meet the patient's calorie requirement. Don't forget that there was a phase between day 1 to day 7 where the patient was not taking his adequate amount. So you will have to provide higher than the requirement of the patient to compensate for the losses that have occurred in the first 7 days. Even if the patient is obese, usually what happens is the dietitian, if the patient is obese, will restrict the calories saying, I don't want him to gain weight. Now, in the first 15 days to 1 month, we are not worried. We here in UAE, we do not worry about the weight of the patient. What I want is to restore the losses and give more energy to the body to perform and all the organs of the body to function. After the patient has got discharged from the ICU, then on the follow-up in the clinic is where I will concentrate on helping the patient lose some weight, helping the patient to get onto the ideal body weight or closer to his ideal body weight, and correcting his other minor blood values. We have the post-hospital discharge. This is very, very important. Here's where supplementation or looking at the diet is very important, because when the patient is in the ICU, we will give them enteral nutrition. We will meet the requirement. When it comes in the post-ICU phase, the patient may not, we may stop, that we shifted the patient down to the medical ward. We will stop continuous feeds. The patient will go on either pump feeds or he will go on to an oral diet. Now, if the patient is suffering from post-ICU syndrome, he is not able to eat. All the psychological aspect that was explained, the mental aspect, the fees, the burden of the finance. So the patient is all stressed about that. The family is stressed about that. Now they start concentrating on the other aspect and forgetting about the patient. So here the role as a dietitian is very important, where you go do a daily follow-up, take care that the patient is consuming his requirement, look at whether he is able to swallow, go through the dysphagia phases. If he is not able to swallow, what is it? Otherwise, what happens is the doctor's order comes as a normal diet or a diabetic diet, and the patient has just moved in after 5 days from the ICU. Can he actually chew the normal diet, or do we need to mechanically adjust the diet? So here the role of the dietitian is very important. Like we say here, the dietitian is 50% psychologist. Most of the time when you see a patient will open up to the dietitian more than to even to the intensivist who is working hand in hand, or the medical doctor that is working hand in hand. They may not be able to tell them, like we know food is a part of the, is a social part of life. So the patient gets a little more free to tell you that, no, actually, I'm not taking my medication, or no, actually, I'm doing this mistake. And that's where you guide the patient and walk with the patient. Then coming to the convalescent or target phase is where we have to meet the patient's target protein and energy. We need to provide them higher. We need to take care that the family is well taking care of the patient back at home. Okay, next slide, please. Okay, here in the acute phase, like I said, we need to monitor the phosphate levels. Phosphate levels should be monitored after every 48 hours to take care that we are not overfeeding and pushing the patient into the refeeding syndrome. Coming to the post ICU, that is greater than the 5th day, indirect calorimetry, if we do have it in the hospital. If no, you use an estimated equation which you have chosen. In case the patient is on the ventilator, then you will use the ventilator based equation or the Penn state equation. Then coming to the post ICU phase is where, if possible, you do a DEXA scan of the patient, and where you will come to know the amount of lean mass that the patient has, and then you can build in by providing higher amount of protein, encouraging physiotherapy, which will help in deposition of this protein into the body and building on the lean mass. I had read through a research which said the weight which is lost in the ICU, it takes an entire period of 5 years, yes, shockingly 5 years, to go back to the patient's pre-ICU admission weight. Also, it takes about 3 years for the patient to stabilize on his psychological ability and get over the phase that he went through. Like Dr. Anita mentioned, the number of machines, the scary machines, the number of pipes running out of his body, the tense faces of his relatives, the burden of the finance. So all that takes about 3 years to wear out. So all this 3 years, yes, you do follow-ups, start with every 2-month follow-ups, continue with 6 months and once a year. You need to keep supporting your patient. It's not he stepped out of the ICU and you just forgot about him. And when we here do a recall or we check back on our patient after 2 years, sorry, the patient has passed off. So I would say about 25% of the blame has to go on our head also. We should have followed up with the patient, just not forgotten the patient. Okay, next slide, please. Nitrogen losses, if care is not taken, like I mentioned all through, around 3 to 4 grams per day of body weight, idle body weight will be lost. So take care, you're supplementing with a high protein diet. Next slide, please. Next slide, please. Okay. Next slide, please.
Dr. Jitendra, the next slide, please. Next slide.
Okay. Okay, I'll continue, and then when we
can't
jump
see
back
the
on
slides now.
No, it's totally switched off.
Reema,
Okay,
you
now
try
another.
from there. Reema, you try. Yeah. Sorry all for this little glitch.
Probably there's a network issue.
There's a network issue with Jitendra.
Are the slides visible?
Yeah, please carry on. Yeah, great. Yeah.
Okay. Now, beating the target without overfeeding and enhancing the performance. How to reach the protein target in the ICU. Now, these are 7 steps which are taken. Calculate the caloric needs according to your specific equation and target for the 70%, reaching the 70% of the patient's nutrient needs in the first week. Okay. In the first week of measured energy expenditure by indirect calorimetry. Usually places which are research basis would have the indirect calorimetry with them. Next step was subtract the amount of non-nutritional calories, which is very important. Sometimes we forget to minus the amount of calories provided by the sedating agents like propofol or glucose or citrate given to the patient. Calculate the daily limit for avoiding overfeeding. When the patient, sometimes what happens is we see this is the dietitian gives, for example, the patient needs 1800 calories and the dietitian, because she is worried about the patient will have loss in lean mass, she gives him about 2200 calories. So she went overboard and the patient will have diarrhea and the ICU intensivist will directly shut off the feed. So now because of diarrhea or because of any gastric intolerance or there is development of air, the patient will be 4 days nil by mouth. Here the patient had greater losses as compared to going slow and being provided with lower amount of energy for a certain period of time and then you catch up with it. So go slow on the entire panel. Select a very high protein to energy ratio. For example, you have feeds, like I would know my feeds out here. We have feeds which are like 1 calorie, 1.5 gram of protein, 1 calorie, 2 grams of protein. So something like this, which is denser in the protein, is more preferred than something which is denser in the calorie. Another thing to be importantly looked at is you look at a feed which is small volume, high protein, high energy, because the volume will be restricted from the doctor's side as they're giving them medications through the IV. So they may not initially be able to give you a direct 1500 ml in your hand or an allowance of 2000 ml in your hand. By the third to the fifth day, that is when you start bargaining with your doctor and telling him you're giving him this much flush. Can I reduce it here? My feed provides me this much sodium. It gives me this much potassium and it gives me this much energy. Can you reduce the flush and let me increase my protein supplement which I'm giving, the enteral feed that I'm giving. Monitor the actual intake during the day and progress to higher than calculated infusion rates. Like I said, go slow, start with the 20 to 30 ml, then 40 ml, then 60 ml, and go ahead. Add enteral protein supplements, as in most enteral feeds will lead to overfeeding. So from the first to the third day, don't go for protein supplementation. Wait for that. From the fifth day onwards, you go for protein supplementation, that is enriching your current enteral feed. Add parenteral amino acid supplementation in case of contraindications to enteral feeding. Now, this is a challenge that we face here in the ICU. Is the doctors are very scared of uh, peripheral parenteral starting, but by about the fifth day, if the patient is not able to meet his needs, fifth to the seventh day, if he's not meeting his needs at 75%, please push, please suggest and try to get the reasons why the doctor doesn't want to start on peripheral parenteral. Now, protein in the post-ICU, choosing the correct formula. We have the hydrolyzed, completely hydrolyzed and partially hydrolyzed. If you go to see, there is no clear research, even through the SPEN guidelines, you can just go by a modular formula. Completely hydrolyzed is not really much preferred. So you can try, unless the patient has a gastric restriction, where we know, I will show you in the picture down. Further, we will see. If the gastric resection has happened, then the patient lacks the ability to absorb the protein through the normal enzymes secreted in the body. Here is when you need to go for partially or completely hydrolyzed. What are partially hydrolyzed or hydrolyzed proteins? These are easily absorbed to the brush border. These are pre-digested and easily digested and absorbed. But again, don't stick to them. We start with normal feed and then we go further if the patient is not tolerating. This is another important thing to remember. Most carriers are linked to the active transport of sodium. The amino acids enter into the move out from the gastric to the blood barrier through the levels of sodium. Monitor the sodium values of the patient, because sometimes you will see the patient is falling at 128, 130. He is not actually absorbing any of your nutrients, and happens to be that the patient gets diarrhea. When the patient gets diarrhea, he is further losing sodium. So monitor these values carefully when you're giving the feed to your patient. Like I mentioned, different sections in the gastric tract is responsible for absorption of different nutrients. Like we see the duodenum for protein. But if the patient has a resection or he has had a bariatric surgery, keep this in mind in the kind of protein that you're giving. Will he be able to digest it? Does he have those enzymes in his body? And what other multivitamins or minerals are missing? Accordingly, you need to supplement it in the peripheral parenteral. Like I said, you know which part is absorbing which multivitamins. So carefully look at what is dysfunctional, which part has got a necrosis, which part is being damaged. In case the patient is from a road transport accident, he's come through an accident, what has got damaged in his body, accordingly supplement it. See, there is no indication that pre-digested or hydrolyzed enteral feeds are better tolerated than intact protein. So start with intact protein. If the patient is not able to tolerate, then proceed further. Because intact proteins are cheaper. The formulas are cheaper, almost half the price as compared to hydrolyzed and completely hydrolyzed. SPEN guidelines recommends to administer about 1.3 grams per ideal body weight or the current body weight in case the patient is not obese, of protein to critically ill patients. Elderly, obese, trauma, burns, acute kidney injury should receive a larger amount of proteins. Now, what happens normally, what I see here is certain dietitians where the patient is obese.
Reema, I think your slides are not moving. Which one are you on? Protein? Or have you moved on?
Not moving. I'm on protein needs, way ahead.
Acha, okay, fine. Take care.
Dr. Reema, can you tell me the slide number, please?
Give me a minute.
Yeah, now it is moving, ma'am.
Fine.
Okay.
Now on micronutrients. Fine, fine.
All right. Okay. So here, ESPN guidelines recommends to administer 1.3 grams per kg of ideal body weight. Yes, we need to calculate the patient's ideal body weight and work on that, or the standard body weight. It's not the current body weight. Now, elderly patients, then the obesity, trauma, burns, acute kidney injury patients, we need to take care of the proteins that are given to them. Do not confuse between an acute kidney injury, third stage kidney injury, the fourth stage, and the fifth stage. What normally happens is some people look at kidney damage and we cut off the proteins. No, an acute kidney injury is only a temporary phase. So you need to provide the correct amount of proteins. This is just a phase where the patient will move out of it. Now, coming to micronutrients, it's an entire whole lecture, inshallah, if we ever get on. But yes, the protein needs need to be calculated as per the phase, the GFR, the other requirements of the patient. Here in UAE, we do a DEXA scan and we find out what is the muscle mass of the patient, and then we decide on this. Okay. Other nutrients that are important would be serum, copper, carnitine. B6 deficiencies are seen in CRRT patients. So supplementation is very important. Then Zinc's deficiency is seen in non-CRRT patient, whether the others are seen CRRT. What is CRRT? Is a continuous renal replacement therapy. So for renal patients, of course, there's a different way of calculating, supplying their multivitamins, looking at their fat-soluble vitamins, water-soluble vitamins. Okay. My next slide is post-ICU discharge. Here, I will run through this a little faster. Remember this term spices. The patient will have something called as swallowing disorder. The patient's, due to the pain that he's suffering from, for all the painkillers that he was getting at the ICU, they may not be given to him while he's in the medical. So he has pain, he is in delirium, there is anxiety, there is gut dysfunction, there is a lot of oral health changes because of no proper oral hygiene done when the patient was unconscious. So all these we as dietitians need to take into consideration. Clinical evaluation needs to be done, a proper supplementation, and involve the dietitian in nutrition from the day of admission until the patient has stabilized back home. Okay. Significant phases are the pre-admission, the ICU, the ward, and post-hospital discharge. I encourage all dietitians to understand you are a very critical post in the entire journey of the patient, because without you, medications are running, pain medications are given, but there is no energy. The patient has no strength. There is anxiety, nobody calming the patient and reassuring the patient, yes, you can. So please remember, you are very important as an interdisciplinary team member, and you can make a change if nutrition is passion. Okay. In the acute phase, we would rough estimate, we would calculate from 20 to 25 kilocalories. This is, we call it as the quick equation. And in the late phase, about 30 to 35 calories. Protein would be maximum up to 1.3. In the late phase, it writes here 1.3, but you can go higher up to 2.5, depending upon the lean mass content of the patient. Don't forget the patient is already entered into malnutrition. Malnutrition is a vast term used. It can be either undernutrition, it can be overnutrition. So remember, your patient is suffering from malnutrition. A lot of enzymes, hormones are upside down. The patient might reflect diabetes. The patient's cholesterol levels are up and down. So you need to gradually shift the patient into a diet which will take care of him. Again, remember, by the 7th or the 8th day that the patient moves out from the ICU into the medical ward, don't scare him by saying, no oil, no sugar, no bread, no white bread. No, you're not scaring the patient. Take him gradually. He was never eating brown bread. Don't tell him on the 7th day, you just have to eat brown bread. No, go slow, go steady. Encourage having whole grains and stuff like this. You have to know how to hold your patient's hand and take him into the next phase of his life. Okay. Studies have shown that protein and energy intake is below that of recommendation in majority of the ICU survivors. In the ICU and during the first year of recovery, long-term and improved nutrition care is urgently needed to support ICU patients in able to reach the nutrition adequacy during recovery. During and after ICU care, optimal nutrition therapy is essential to improve the long-term outcome. Like I said, the dietitians are very important. to reduce the likelihood of the patient from becoming a victim of the critical illness. A patient who is into suffer from a critical illness will tell you, this is what I saw during COVID. I had COVID. After that day, I never stood up. After that day, I had no strength in my body. We are to blame. We didn't guide him well out of the hospital. Okay. It is a multidisciplinary approach. Remember, you're very important. So take active part, put down a diet plan, call the patient back every 2 months for up to the first year. After the first year, that is from the first to the third year, it's every 6 months. And from the third to the fifth year is 1 yearly assessment of the patient. This slide was already well explained, so I will just skip this. What are the changes that happen in post-ICU care syndrome? There are cognitive impairments, there are long-lasting pulmonary dysfunction, sustained muscle weaknesses there, long-term kidney issues can develop, and immunosuppression and persistent inflammation. So as dietitians, we know we play an active role in all of this. If you give an antioxidant-rich diet, encourage the patient to take his meals at regular intervals. His physiotherapy team is encouraging him to make exercise, move around. It will make a great difference. The risk factors, like we know, are modifiable and non-modifiable. Now, coming to the modifiable risk factors, if we did a proper nutrition, yes, the patient would not lose a lot of muscle and not enter into sarcopenia and not be very tired, and encouragement would do a great job. Non-modifiable is the severity of the disease, which again, I would say it's not totally non-modifiable. Even if there is, for example, a patient suffers from COPD, we know there are phases where the patient is in the active phase and where he is in the stagnant phase, where he's in the active or the dormant phase. That is where you're going to build on his nutrition. So nutrition plays a very important role once again. Okay, this is what is very important. Post-ICU care syndrome, follow-up system, very important. Physician and pharmacist, even the dietitian plays an important role. See that you're providing adequate calories, adequate amount of protein. Sometimes you will see psychologically the patient, like Dr. Harsha that explained, patient has lost hope. He feels like, no, now I don't feel like eating. And here in UAE, because the fresh chicken availability is low, they say, chicken mein baas aata hai, machhi dil nahi hota hai. So as a dietitian, guide him, teach him different ways of cooking, him or his family members. Encourage taking liquid meals in between, encourage taking supplements in between the main meals. This is all going to add to his energy intake and his protein intake. Of course, we back in India, when I studied in college, we even did enteral feeds, those were known as kitchen feed. Today, here in the UAE, we totally discourage kitchen feed, but something close to a kitchen feed, not necessarily administered nasogastrically. It can be made into an high energy milkshake. You can add protein powders to that, encourage them having a glass in between their meals if they haven't eaten. We have policies here which speak about food first. So encourage the patient to finish his breakfast. Once he's discharged, he's at home. First, eat your breakfast as much as you can. Eat 2 mini breakfasts. And after about an hour, try to take a milkshake or something, which is an enriched milkshake. Then about an hour, hour and a half, then he takes his lunch, maybe 2 mini lunches. One would be the cold lunch or his warm lunch if he likes, like the soup. Maybe using vegetable proteins like dals, pulses, we're very rich with that back in India, or using animal proteins like egg, meat, fish, chicken administered to the patient. After that, he takes his cold lunch, that is salad with his yogurt. I love the existence of yogurt and this habit that we do back in India. We all know they have the positive microbes present in the yogurt, which strengthens what I tell the patients here. It is like a marham. It's like a cream. The word marham is the same meaning. It's like a cream. It heals the gastric from the inside. And don't forget, we are goddesses as dietitians, because food is the way to everything. If proper nutrients are supplied, proper protein, multivitamins are taken care of, you can help the patient come out of the depression as well. Sometimes the depression can be handled with proper B12 supplementation, zinc supplementation, the muscle weakness through magnesium supplementation. So know your importance and play it. Okay. Oral nutrition is most common mode of nutrition provision in the post-ICU period. Like I said, when in the hospital, we are giving enteral feed. Once discharged due to financial reasons, the support will be stopped. So encourage or teach your patient or the patient family, in fact, how to provide the kitchen feed, but in the form of a milkshake, which has flavor, which has taste, and the patient will build on it. Like, so one important thing that I carried back with me is here I taught them when I initially came about 20 years ago is chicky. I really like the idea of chicky. Till seeds or the nuts unsalted mixed with jaggery, which will also help with a little amount of make the patient happy. He's able to enjoy something crunchy and nice. And I see that most of my patients take that. Or you give them a fruit salad, or you give them pureed fruit, which is put in the fridge, cooled down, or made into this crush ice texture, and he's eating it. So he's like, I'm not put out of all sweet dish also. That could be a sweet, could be an encouraging factor. Like what I see is when you're talking to the patient for a post-bariatric patient or a weight loss patient, and you say, yes, you can have a sweet. And they're like, oh, I know this patient is coming back. If I told him, no, 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 I know this patient is running away. So you should know where you want to give liberty to your patient and where you want to restrict your patient, and slowly guide him to take the path of health with his own, as his own choice, not you're forcing it on them. Let them select it as their own choice. Post-ICU care syndrome impacts about 80% of the patients who survive the ICU. Most of the patients will leave the ICU on the wheelchair or be transferred by the bed into the medical ward. We need to take care from the day of admission and be sure that when we transfer this patient into the medical ward, he is fit, he is conscious, he is able to move. The physiotherapist has already taken over, and then he's moved to the ICU ward. We will have better outcomes that way. Okay, this is the latest paper, which was released in July of 2024. And we see nutrition therapy for the prevention of post-ICU care syndrome. You can take a picture of this and then you can go through and read it. It very clearly writes that proper nutritional support was given. ICU-acquired muscle weakness or the PICS would be way low. Physiotherapy would be initiated and the patient would have more strength to move around. These are my references and I'd like to say thank you. Want to call on the questions, please?
Thank you so much.
Yeah, Dr. Reema, big thank you. Over to you, Sandhya.
It's my pleasure. It's my pleasure.
Yeah. So it was a very detailed session. There are a couple of questions. Are there any tools, specific tools that you use to assess the additional nutritional demands in the ICU when you see that the ICU stay is getting prolonged?
Okay, you do a proper assessment. Like I tell them, like it's like we say assessment, screening. Yes. So you go back for your screening and assessment on the first day. You go back on the third day. You go back on the fifth day. What I do here, practice, and what I put it through the policies is every second or the third day, you go back for your assessment and screening. You will see yourself on the first day what you had asked from the relatives, that bayan or what they tell you, over the seventh or the eighth day will be completely different. So here you have to do a proper assessment. If you have access to indirect calorimetry, that is the best way. The other way is to take values from the PEEPS value from the ventilator, take that and put it into your Eritton-Jones formula. And from that, you will come to know what is the patient's resting energy expenditure. Add about 500 to 700 calories to that, and then start from there, 25%, 50%, 75%, and then go higher.
Okay. Okay, thank you for that, insight. And then there is another question, they're trying to ask, is there any specific nutrient that you would emphasize which will help the patient cope up the post-ICU syndrome? So whatever physical issues that they are facing and things, do you think that can be dealt, very well if at all we are giving them some specific nutrients?
I am in love with B complex. So I go specifically with B1, B6, B12. Then we go with zinc, we go with magnesium. You take care of the vitamin C. You check on the vitamin D levels. So if you're taking care of these basic vitamins, you will take the person to a greater length further, reduce the risk of mortality, and help with the patient. Once the patient is discharged, like I said, for the first 1 year, it's every 2 months. On his fourth visit, now start looking around for all other multivitamins or folic acid and biotin and blah and blah. By now, you know that your patient is someone who is capable of doing it and will take this further, will take a daily multivitamin. This is when I said screen, assess. Yes?
Yes.
You will know whether your patient is actually being able to do it. Like back in India, when I studied and I can never forget this example. When I was, because born and brought up in UAE, for me, a chapati is this much, just this much. Yes, it's a small peda of chapati. And we had a farmer who came up to us, and when we counseled, and he said, "I take one chapati, which is like half a kilo." How is it ever possible? But she came from way inside the village, and
Yeah.
she was, iron levels were way high. So she said, we take bajra atta and then we put it on the tawa and we seko it well, and we have that along with a dal. So looking at her body, you would say she's malnourished, but really her muscle strength was way higher. Her blood values were beautiful. Only she had tripped and broken a bone, but her healing also didn't take her about 1.5 months. She was well off to do within 15 days because there was exercise, the body was moved, the body was exercised. So that's how you will know the compliance. If this patient came to me and I told her, take this multivitamin, this, no, she doesn't understand the importance of that. So go slow, come down. Like my project was from the plan to the plate. This is very, very important. This we see sometimes the dietitian is putting beautiful plans at the ICU. And can the family even understand this? Can the family even afford this? Is the patient even ready to change on that panel? Just keep this in mind. It's very important not to just wear a white coat and write. It's very important.
So
Put yourself in.
So you
Very,
have that
very important.
protocol, Reema, of the patients coming back to you in the OPD?
Yes.
You have that
Yes.
protocol there
Yes. We do.
for all the
Yes.
patients?
Yes, with all the
Do
patients.
we
After the,
lose them? Yeah, do you lose them the moment they are better and they stop coming to you, or do you have a system of follow-up?
depending upon the socioeconomical status, yes, you will lose. But those who are compliant, you will be able to take them for a longer journey with you. And those who have once got confidence on you, they are your lifetime patients.
Yeah. So you have a follow-up system.
Yes, we do have a follow-up system. Before discharge from the hospital, you give them an appointment within the first 15 days. That's when you will be bombarded with questions.
What is your dietitian-patient ratio there? Just for, because we always struggling with our OPD patients. What's your ratio there?
The ratio is one dietitian to, inpatient ratio is one dietitian to every 10 patients.
Wow.
Yes. And the OPD sector depends upon the kind of patients that walk in, because here we've not yet specialized in my hospital, we've not yet specialized. The previous hospital that I worked with, we had specialized. So we had about one dietitian, 16 patients a day.
Okay. Thank you so much, Dr. Reema. That was very, very
Thank you.
educative and enlightening. Very well done. You've really taken us through the journey of ICU and post-ICU. Thank you so much.
Thank you so much for having me on board.
Is there any question? Done. No other question. Achha, last question.
Last question I have, where I was, just trying to ask her. See, due to the diagnostics and things, many a times whatever we plan for a patient, we are not able to deliver. Is there any specific way by which you try to catch up those peaks? And whatever you plan to catch up, are you able to really do that, practically implement that? That is my question.
Yes. So, I calculated the patient's needs. Yes. I'll get this in a very straight example. I calculated the patient's needs. Let's say my patient needs, for a round figure, 2000 calories. I have on the first day given only about 600, 700 calories, right? First 3 days is just that much. Then I am touching about 1200 calories. I'm going calorie deficient all over here. Once I start meeting the needs, I will go from 2000 and I will go higher by 200 calories on each day until his discharge. Then once there is a home care plan, if the patient is yet on enteral nutrition, I will divide it every 3 hourly feed, smaller volume, higher concentration of the energy and the protein. And I will stick to that. If the patient is going home eating orally, then I will add in these, like I told you, these nutrition supplements to be had if it is affordable. If it is not, then home-based milkshakes which are made. So there is a fruit, there is a nut combination, there is jaggery for the sweetening, this kind of thing. And like we commonly now, we also have stevia, which is a plant-based sweetener. So that could be used. Artificial sweeteners, I don't support that because we know all the latest researches which I implemented. So I would yet personally prefer jaggery even to stevia because a small amount will not hurt. Stevia again has extractions through alcohol. So I'm not too happy about it. All right. It will come later. Maybe they have some researches. I really don't know. But I would yet prefer, I don't know. Yes. Back when I was in college, we had our ma'am She would not support using artificial sweeteners. It took 22 years down my entire career line, and we just came out with the idea that yes, they are damaging. Yes, they are increasing the risk of cancers. So I
It's
don't
a
really
vicious
see.
circle.
It's
We
a
are
vicious
now,
cycle.
yeah, yeah.
Yes,
We
yes, yes.
advise
It's a
and
vicious.
then we again remove. We are
Yes,
great ones at that.
yes,
As
very
you
true. I
said.
agree.
Thank you so much.
Thank you.
My
Thank you,
pleasure.
Dr.
I
Reema,
think I
for a
will, yeah,
wonderful
yeah. I
session.
think, yeah, we wind up the session. Thank you to everybody. A big thank you to
Thank
Dr.
you all
Nanda
for
Kumar
listening to me
Jero,
and
President, yeah, GAPIO, and the organizing committee for this opportunity, and Dr. Sushil Jain, and a big thank you, Dr. Jitendra, for handholding and coordinating all the speakers, and Sandhya, big thank you to you.
Thank
Really
you, ma'am.
grateful to you all for accepting and being here on a Saturday evening. And the participants, of course, need a big cheer. Thank you for being here on a Saturday. Thank you, everybody.
Thank you, ma'am.
Okay, bye-bye.
Thank you, one
Bye.
and all. Thank
Bye,
you,
Dr.
everybody.
Reema. Yeah, Dr.
Bye-bye.
She has already left.
Thank you, ma'am.
Yeah.
Bye.
Bye.
Bye, Dr. Kanta. Hi. She's always there. Thank you.
Dr. Anita, ma'am, with your permission, can I end the session?
Yes, please. Thank you.
Thank you, ma'am.
Practical suggestions.